Hello, hello.
So, a very good afternoon, and we are shortly starting our clinic. We are waiting for DDG madam to join, so just give us 2 minutes.
Hello, hello.
So, a very good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Madam, Dr. Urvashi Singh, directors from NIRT Chennai and NTI Bangalore, state TB officers, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, and others. A very warm welcome. Introducing the faculty from NITRD, I am Dr. Neeta Singla, and I am the Nodal Officer DRTB Center at NITRD. On my right is Dr. Rupak Singla. He is consultant in Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is pulmonologist at NITRD. I now welcome our director, Dr. Upasna Agrawal. Dr. Upasna, apart from being a director, she is a very senior faculty with us and she heads the Department of Internal Medicine for more than 20 years. And she runs a very successful HIV TB eco clinic called eNischit. I request her to give her introductory remarks.
Thank you, ma'am. Thank you very much. It is indeed my pleasure to be able to introduce and welcome all the esteemed faculty who have joined today on behalf of NITRD. It is a great activity, I know, that is being spearheaded by you and Dr. Singla. And I am just actually, and I am fortunate enough to get that opportunity. So I welcome everyone who has taken out their time today, and especially our DDG ma'am, who is traveling, and still her commitment is such that she has taken out time to join the session. And I also welcome today's expert, Dr. Sural from MAMSI. So your comments, your educational points will be very, very helpful because as far as TB physicians are concerned, we do lack a little bit in disciplinary systems when they get TB, like TB of the spine, TB of the eye. So, and TB spine we are seeing with more and more frequency nowadays. So I welcome you. And with these few words, I hand it back to Dr. Neeta.
Thank you, Dr. Upasna. We just got a message from Dr. Urvashi that due to some technical issues, we are not able to hear her. So she's not able to join us. But we are joined by Dr. Srinath, who is director of NIRT Chennai. So a very warm welcome, Dr. Srinath.
So thank you, Dr. Neeta, and good afternoon, everyone.
Yeah, a very warm welcome, Dr. Srinath. So now we start our clinic in our series of different states that who discuss their important and difficult to treat TB cases. Today's case is from Chhattisgarh. The case presentation is by Dr. Praveen Kumar Dubey, who is a DN resident, then in the Department of Pulmonary Medicine at AIIMS Raipur. The state expert is Dr. Ajay Kumar Behra, who is also the Zonal Task Force OR chairperson for East Zone, and he's also the for Department of Pulmonary Medicine at AIIMS Raipur. The national expert is Dr. Sumit Suhal, who is Director, Professor, and Head of the Department of Orthopedic Surgery Department in Maulana Azad Medical College, and he's also the in charge spine clinic at Lok Nayak Hospital. Sir, a very warm welcome. And our DT3C expert is Dr. Rupak Singla, who is consultant in Department of TB and Chest. So now I request Dr. Dubey to present his case.
Thank you, ma'am. Good afternoon to everyone. Now, I am presenting a case. The topic is, am I audible?
हाँ तो डॉक्टर प्रवीण जरा इसको प्रेजेंटेशन मोड में कर देंगे, फुल स्लाइड हो जाएगा।
मैम प्रेजेंटेशन मोड में ही किया।
अच्छा, इधर नहीं आ रहा है।
ठीक है मैम, मैं एक बार फिर से कर।
आ गया ठीक है, इट्स ओके, इट्स ओके, इट्स इन प्रेजेंटेशन मोड।
आ गया सर। गुड आफ्टरनून टू एवरीवन। Today I am presenting a case, the TB treatment failure. Check the blood, not just the bug. A 39-year-old female patient presented with back pain for last 14 months, which is insidious in onset, gradually progressive in nature, dull aching type, gradually increases in intensity, especially in the last 3 months, radiating to both upper limb and persistent throughout the day. Worsening at the night, pain aggravated by physical activity, so unable to do her day-to-day activity, relieved with rest, initially responded to analgesic, but later, in spite of analgesic, patient unable to sleep due to pain. There is no bladder and bowel involvement reported so far. Second is the on and off fever for last 9 months, intermittent in nature. Fever is typically low to moderate grade, not associated with chills and rigor, often in the evening or night, and it is associated with generalized weakness, fatigue, and significant loss of weight. And the loss of weight is from initially it was 62 kg, which is reduced to 49 kg, and there is loss of appetite is also associated with fever, and the fever is subsided with medications. Past history: on December 2023, patient first time visited to the orthopedic surgeon where the X-ray of his whole spine was advised. X-ray of the spine suggestive of bony destruction along with space narrowing, which is suggestive of port spine. In view of clinico-radiological suspicion of port spine, MRI was advised. This is the MRI taken on the 10th of December 2023. The first image is T2 wet SAG image, cervicothoracic spine, in which there is showing the C7 vertebral body collapse. C7 vertebral body collapse. Along with that, there is paravertebral abscess is there with abscess compressing the dura at C6 to T1 level. This is demarcated by the blue arrow. And apart from that, there is a prevertebral abscess is there, which is at the level of T3, which is extending from T3 to T7 level, which is depicted through the blue arrow in this region. And the second image is the steer sequence thoracic spine images, in which we found that there is T1, T9, T7, T12, and L2 vertebral body abnormal signal lesion is seen, which is also demarcated by the blue highlighted at T9 to T12 level. And the MRI is suggestive of active multifocal spinal disease. Based on this clinico-radiological findings, ATT HRZE started under the NTEP since January 2024. After taking 1 month of therapy, patient was lost to follow-up. Again, since June 2024, patient visited to the orthopedic surgeon from where the ATT was restarted according to the weight band and registered under NTEP. After 2 months of ATT therapy, patient was shifted to the HRE CP phase as per the NTEP protocol. In the meantime, patient was compliant and adherent to the therapy. Until January 2025, patient took ATT as per the guideline. Patient first time reported to the AIMS Raipur in January 2025 as there was clinical worsening. What are the clinical worsening? We saw that patient intensity of the pain is increases and there is significant loss of weight was present. Initially, patient can do her day-to-day activity, but now when she presented to us, at that time, she can't able to do her daily activity. And along with that, when she visited to the neurosurgery department, they advised the follow-up MRI, and MRI was done in the month of 7th of January 2025. This is the MRI which is done on the 7th January 2025. The first image starting from the left to right, the T2 weight sac, there is prevertebral abscess is seen. Along with prevertebral abscess, there is blue arrow is showing the abscess compressing the dura from the front. And in the T2 weight axial at T1 level, there is the blue arrow demarcating the abscess compressing the dura anterolaterally. This is the. And in the third image, T2 weight axial at C7, there is prevertebral abscess which is depicted by the blue arrow, and the yellow arrow is showing the abscess compressing the dura from the front, which is showing the disease progression of the disease. So there is showing the prevertebral and paravertebral abscess was seen in the follow-up MRI on January 2025. So CT guided pus aspiration was done on 15th of Jan 2025. Of that aspirated pus, CBNAT was sent, and in the CBNAT, MTB detected and rifampicin resistant not detected. And along with the CBNAT, that pus was sent for the liquid culture, and the liquid culture report was came on 15th of February 2025. There is shown of growth of Mycobacterium tuberculosis complex after the 21 days of aerobic incubation. And on that culture of the Mycobacterium tuberculosis complex, the LPA was applied, and the first line LPA suggestive of rifampicin or isoniazid both are susceptible, and in the second line LPA, second line injectable and fluoroquinolone are susceptible. As patient took ATT as per protocol according to the weight band, compliance and adherence was the confirmed because patient took as per her weight band, and patient daily took ATT in the fasting in the morning. And in spite of 9 months of ATT, there was clinico-radiological deterioration was seen. So therapeutic drug level of first line drug of rifampicin and isoniazid was sent, and simultaneously the culture was sent for the extended DST at NITRD New Delhi. When we performed the therapeutic drug level, we found that after 2 hours, the patient having isoniazid level was low and rifampicin was just above the normal range, because the isoniazid level is came as 1.43 and rifampicin is 9.34, and the therapeutic range is after 2 hours is 3 to 6 for isoniazid and 8 to 24 for the rifampicin. So after second hour, the isoniazid level was low and rifampicin level was just above the normal range, and after 4 hours, both the isoniazid and rifampicin levels were low. The isoniazid level was 0.84 and rifampicin was 4.61. And after 6 hours, both isoniazid and rifampicin levels were low. Isoniazid was 0.82 and rifampicin is 3.75. So on in conclusion, the TDM was performed and both the isoniazid and rifampicin level were low at second hour, 4th hour and 6th hour. Simultaneously, along with the TDM report, extended DST report came, and extended DST report suggestive of sensitive to bedaquiline, linezolid, cycloserine, clofazimine, pyrazinamide, ethionamide, ethambutol, PAS, delaminate, moxifloxacin, high dose and low dose both, and second line injectable. Cause for the low drug level of first line ATT was evaluated by the gastroenterologist, but no obvious cause was established. Final diagnosis is treatment failure spinal tuberculosis, microbiologically confirmed. In view of clinico-radiological worsening and still culture was positive at the end of 9 months of ATT, as TDM for first line drugs were low, so all oral regimen along with amikacin was planned for this patient. And the regimen decided was all oral regimen, all oral longer regimen along with amikacin, and the drugs was linezolid, clofazimine, linezolid, bedaquiline, levofloxacin, clofazimine, cycloserine along with amikacin. And the modified all oral longer regimen was started on 19th of March 2025. And according to the weight band, bedaquiline was given, bedaquiline, levofloxacin, linezolid, clofazimine, cycloserine, and amikacin was given to the patient. And it was started on 19th March 2025. After 3 months of all oral longer regimen along with injectable amikacin, what we found that there is complete resolution of the abscess. This is showing in the 7th of January, there is a C7 to T1 levels is a paravertebral abscess and dural abscess is seen, which is indenting the dura. And there is T1 to T7 level, thoracic level, there is also paravertebral abscess. Now it is completely resolution is seen, what we seen in the follow-up MRI, which was done on the 23rd June 2025, which is also seen in these follow-up images. So what we found after 3 months of therapy, that there is complete resolution of the abscess. Along with that, the marrow edema is also reduced. And there is no any new radiological finding was seen in the follow-up MRI. So these are the timeline of our patient postpine with paraspinal abscess on 10th of December 2023. There was a multifocal spinal tuberculosis, T1 to T2 hypointensity, D1, D9, D10, D12, and L2. And on 7/1/2025, what we found that we microbiologically confirmed the port spine by CBNAT and MGIT proven, and the follow-up MRI suggestive of disease progression. And after 3 months of therapy, what we found that after 3 months of all oral longer regimen with amikacin, what we found that there is resolution of the abscess along with decrease in the marrow edema. So what we found in our follow-up image, the serial imaging indicate excellent radiological improvement with resolution of the abscess, regression of the marrow edema, and no further vertebral collapse. And these findings support effective control of infection, most consistent with the treatment responsive spinal tuberculosis. And some chronic residual changes remain, but no active disease is seen in the latest scan, which was done on 23rd June of 2025. And clinically, patient was improved. Initially, cervical collar was applied, but now it was removed. And now she can do her daily routine activity. And while examination of the upper limb, it was found that it is ranges between grade 4 to grade 5 level. Now, our the discussion questions is, first, what factors should prompt suspicion of treatment failure or drug resistance in spinal tubi, especially when the culture is still positive despite prolonged ATT? How does therapeutic drug monitoring influences the decision to switch from first line to second line or MDR TB regimen? And the third question is, when should an all oral longer regimen for MDR TB be initiated in extrapulmonary spinal cases, even in the absence of genotypic resistance? Thank you.
Thank you, Dr. Praveen. An excellent presentation. I think you have clarified everything. So I open the forum for discussion. If there are any questions on the history of the patient or any investigations, we can take them now.
We usually see such cases quite frequently these days because we have now the facility for TDM. So my only query from this case and many other cases with which we are dealing on daily basis, in this patient also we declare him as clinical failure despite being sensitive to both the drugs. And when we change to the second line regimen also, and yes, Dr. Dubey has clearly mentioned that there was no malabsorption. They have already been ruled out and have shown the patient to the gastroenterologist. But in the second line regimen, also most of the drugs were oral preparation. So, is there any? I think a lot is pharmacokinetics of the drugs plays a lot of role in such cases. Assume like the first line ATT were not getting absorbed, but the second line ATT, despite being oral, they get absorbed and there was a clinical improvement. Or there is more into it, like with rifampicin IM, which we might be missing. So this is like I was just wondering, like if
Yeah. So it
can
can
be
be
answered.
relevant question. Maybe do we take it later? Because
Yeah, I think so. The question is very, very relevant. But since we have Dr. Sural with us, and I mean, we spent quite a number of years of dealing with the TB of the spine. So we would like to hear from him about his experience of dealing with TB of the spine. How many of them they present like this? When do they feel that now the treatment can be stopped? And which treatment regimen most of his colleagues are using? So, Dr. Sural, can you educate us on these
Yeah.
issues?
Yes.
Dr. Sural, I'll just hold you for a minute because there are some questions on the history of the patient. So we'll take them first. So first question was, were there any X-rays done for this patient? Dr. Praveen?
Ma'am, the X-ray was done only in the first time visit, ma'am. But after that, every time patient was followed with MRI, ma'am.
So there is no lesion in the lung, even now.
Yes, ma'am. We perform CT scan of thorax, ma'am. In the CCT thorax, there is no lesion in the lung, ma'am.
Okay. And the extended DST was phenotypic of or
Yes,
genetic.
ma'am. With
Both. I think you've done the LPA as well as the midget.
yes,
So both were done.
yes, ma'am.
Okay. And then somebody is asking, why have you added Amikacin to the regime? So I think we'll take it when we discuss the treatment part. And what are the causes of low TDM? I think Sir Dr. Sural will be, informing us that. So over to you, Dr. Sural, sir.
Yeah, thank you so much, and very good afternoon to everyone. So I would like to share that as an orthopedic surgeon, generally the trend was till now, uh, maybe up to 18 or 24 months of anti-tubercular therapy. So when we looked into the literature for evidence-based guidelines, and in 2016 we made the index TB guidelines for India. That time, based on the evidence, we could bring it down to 12 months, which even in the 2023, the extrapulmonary TB training module, the same regimen continued. However, a lot of studies have been done, and one of them is a very important study from India, which is a randomized control study from Mumbai, Dr. Abhinay et al., which showed very clearly where spinal tuberculosis 6 months versus 12 months of anti-tubercular therapy, randomized controlled study of 52 cases of 6 months and 48 of 12 months. And they found that the same results were there in both the groups. Subsequent studies from AIMS also have been published, where they have shown that 6 months versus 9 months is almost similar results. So, as I said, that orthopedic surgeons generally tend to give it the treatment for much longer periods. And in this particular case, there was at 9 months of anti-tubercular therapy, weight loss, as well as sort of no clinical response to the treatment. So in such a case, we generally would make all attempts to know whether such a case is a multi-drug resistance case or not. Otherwise, if we do not get any samples for multi-drug resistance, then generally you continue the ATT for 12 months, and sometimes they extend to, because even the index TB guidelines are on a case-to-case basis may be extended to up to 18 months also. So actually this case is quite an eye-opener, because in my experience of so many years, we have not had this opportunity of getting the therapeutic drug monitoring done. So such cases, if the patient is not responding to anti-tubercular therapy, and we take out the sample and find that the CB NAD is showing still no rifampicin resistance, and the MJIT has grown, the culture DST is showing sensitivity to all drugs, then there's a dilemma that what to do. Should we continue the treatment? Because that is what all the orthopedic surgeons are saying. But having said that, Dr. Singla, may I just extend a little bit of our experience about the duration of ATT?
For sure, we are here to to hear from your experience, because you are in TB spine for quite a long time.
So actually, right, I was initiated into this because when DOTS came up in 2012 to 13, we started doing some research, because we were, right from our time of PG, all orthopedic surgeons are told you have to give 18 to 24 months ATT. And when DOTS said that intermittent therapy, that also 6 months, so then the question came that is it working or not? So the first study that we did was very interesting, and it was a Ciproflox labeled technician bone scan. So we did in 25 patients of extraspinal and 9 patients of spinal tuberculosis. All of them, there was this Ciproflox labeled technician bone scan, which the INMAS, Dr. Ravi Kashyap, who's no more, he had developed this along with the DRDO and after DCGI approval. So we had given this, and Ciproflox, which gets adhered to actively dividing microbacteria. So we found in 25 extraspinal and 9, all of them were showing uptake. And I was surprised that 4 of the 25 extraspinal and 2 of the spinal within 3 months showed no uptake. And all of them at 6 months showed no uptake. So that was really surprising that 6 months tuberculosis, spinal tuberculosis, extraspinal tuberculosis are not showing any active disease. So then I decided to do some other studies, and one of the other studies was based on the MRI. So we did 50 cases contrast MRI before starting antitubercular therapy and at 6 months, and we have now a follow-up of 5 to 7 years of all these patients. So it was, we divide the results, I could categorize into 3 groups. One was who showed complete resolution of the contrast MRI at 6 months. And there was a very small group that was only 6 cases out of 50. Whereas majority, 36 out of 50 patients showed partial uptake at 6 months, but all of them were clinically healed. And all of them, we stopped antitubercular therapy at 6 months, and now it's more than 5 to 7 year follow-up. All of them remain healed. Now, among the MRI, contrast MRI, which showed no resolution at 6 months, 2 of them had clinically healed, and we stopped ATT at 6 months, in spite of the MRI showing no resolution. And they continue to be healed. Among the 6 cases of MRI which showed no resolution at 6 months, 3 of them we had to extend the therapy, and 3 of them were MDR. So what I'm trying to say is that although traditionally we are saying the orthopedic surgeons continue to say that 18 to 24 months, but Index TB guideline has got it down to 12 months, extended on a case-to-case basis to 18 months. But we have shown, and research is still showing that even 6 to 9 months is good enough. In fact, WHO currently says that because there is no robust endpoint, to detect that okay, it is healed. So in the absence of such a lack of endpoint, in the absence of an endpoint, they are recommending you may extend to the antitubercular therapy. So in this case, when 9 months are over and there is no response, then it is actually a dilemma that why the resistance is not getting detected. Because I have seen a few patients where we keep on doing the test, and it keeps on showing sensitive, and sometimes it shows resistance later. But here in this case, both the DST as well as the CBNAT was showing no resistance, and it is very interesting that the therapeutic levels were low. I think this is the need of the hour. Then that means we should be checking the therapeutic levels for cases who are not responding. And I would also like to draw your attention to another study which we published, where we did 100 patients from whom we could get the samples. So they were all cold abscesses or samples from other joints. And out of this 100 patients, we found new cases of resistance in 5% cases, and 10% who had already taken antitubercular therapy. And this resistant pattern was that in some cases there was rifampicin resistance by CBNAT, but no growth in the culture. Some were showing growth in the, resistance in the culture, but CBNAT not detecting resistance. So now we have a third category. So we should, I think, in all samples who are not responding, all these samples should be subjected to CBNAT as well as DST liquid culture, as well as a therapeutic drug monitoring. So that is what my take-home message of this beautiful worked up cases.
Thank you so much, sir. Now we go to our state expert, Dr. Ajay Kumar Behra. Sir, are there any comments from your side for this case?
Because many times it is difficult to treat dog resistant tuberculosis. But we have find many sensitive extrapulmonary tuberculosis is a severe form of tuberculosis. Usually guidelines will give you ATT for 6 months, but extensive form, that is severe form tuberculosis, will extend to 3 to 6 months. That is 9 to 12 months. But since this patient after 9 months there is no disease progress. So we are thinking it is that is patient is not improving or failure. So that's why we are thinking, and we are also discussed with Dr. Simla sir, and we'll discuss regarding this case, not only this case. So many cases we have discussed. Dr. Simla, many thanks to Simla sir. He's also coordinating with us. These last 6 months we are getting 4-5 patients of a sensitivity patients. Those who are not responding to this usual first line drugs. We are sending the therapeutic total drug monitoring, and after giving these high dose or second line drugs, the patient is improving. So this is a very interesting case. Yes, ma'am.
Thank you, sir. Dr. Singla, Dr. Praveen has raised 3 questions. What factors should prompt suspicion of treatment failure in such cases? And how does TDM influence your treatment? And when can we start all oral regime in a patient who is sensitive to all the drugs?
Thank you. You see, at the outset, I must thank the team from AIMS Raipur, Dr. Behra and his team, for having this case being presented, because these are the cases of extrapulmonary TB, which are very difficult for the chest physicians to diagnose and what action to be taken, and we need the help of good orthopedic surgeons. So, and also like to thank Dr. Sumit Sural. I've been seeing him for last so many years that he's taking interest in the bone TB. He has done original studies, and they've also followed up the case systematically by doing MRI scan. So he knows about that, what are the issues, and also he talked about the duration of the NETV medication to be used. Because conventionally, most of the orthopedic surgeons, we find it difficult to tell them that anything less than 18 months works or less than 12 months works. But since he has gone through the literature and he himself is practicing, that like he showed his own experience, that in few of the cases even 6 months was enough. In some of the cases he had to extend to the 9 months. But it's clear when to finish at 6 months, when to finish at 9 months, because end of the treatment in all extrapulmonary TB is an issue. It requires a lot of personal experience and a lot of reading of the literature, learning from others' experiences. Then they come to the conclusion that okay, in this case, that we can stop the treatment. Now, having said that, let us have a look about the TDM once again. That what this issue is, how does it help us? The first question comes when we should think of therapeutic drug monitoring. So when you find a patient is on anti-TB medication, and despite that not showing clinical, radiological or pathological response, that is the step number 1. Then you do the samples, repeated samples. Like in lung, we can have repeated samples. In extrapulmonary TB, we can have sample only once or twice. And that sample is showing that the drugs are sensitive. Like in this case also, fortunately, they had an access to the good orthopedic surgeon who took out the pus. And they found that on genotypic tests, that is CBNAT and LPA, they were all sensitive to the first-line drugs as well as to the propinolones. And when the culture DST was done at our institute, we found that sensitive to all the second-line drugs also. So once this has been done, then before going for TDM once again, we have to ensure that patient is on adequate regimen, on adequate dosages as per the weight of the patient, and has shown good compliance. Because these are the most common reasons of a non-response to treatment. So we have to look for all these three factors. We also have to look for any other factors which could be causing immune suppression or poor drug absorption. And then once it is, and let me tell you, you see, very interestingly, what we have found, I'll share with you our experience of the last 75 years, 75 patients in the last 7-8 years, that there also we extensively investigated them. Dr. Ahuja from AIMS Gastro was also with us to help us. But in practically none of the cases we could find a reason why the drugs were not being absorbed. So they've done all the commonly absorbed, commonly available drugs. He even did the endoscopies in 2-3 patients, took the biopsy also to look for things like tropicus flu, but still or celiac, but could not find anything. That is a field reality. I don't know the reason. So once we decide to do the TDM, very important is that we have to instruct to the patient that he or she must take the drugs for which we are doing the TDM at the same time of the day. Usually we keep as 8 a.m. so that because we need to draw the blood at least 2 hours. So first sample we draw after 2 hours. So patient takes at a stretch for 7 days minimum, the same time of the day, the correct dosages. And then on 8th day, patient comes to us. We sort of admit them only for a few hours in our ward, and we withdraw 3 ml of the blood. And then there is a process. This is centrifuged, and then the plasma is taken out. Then we add 10 microliters of the 5% ascorbic acid, and then that sample is ready to be sent to the laboratory. Initially, can you go over the next slide, please? You see, we started doing this TDM right from I think 2016 onwards. So just a small experience of 8-9 years only. And then at one stage, this is a simple study which we collated our data that what is happening. And we had 75 patients in our cohort, out of which 60% were pulmonary TB and rest 40% were that is extra pulmonary TB. And when we did the blood levels in this group who are taking the drugs adequately but not responding to treatment, we found that 85% of these, that is 64 patients, had low levels of any drug, whether it is INH, rifampicin, or pyrazinamide. So that means in these cases, a high percentage of patients are likely to have low levels who are not responding to treatment, but despite being on the adequate dosages and good compliance, and 15% had normal levels. And also it was found when we looked at the drugs, which are the drugs which are more likely to have low levels. Here we found that in 80% of the patients who had low levels, rifampicin level was low. And INH was found to be low in around 40% of the patients. Pyrazinamide was not done the more frequently. So the reason was by the time the patient had come to us, the PZA had been stopped. So they were on 3 drugs, INH, rifampicin, ethambutol. So we had few patients where we had the data about the pyrazinamide. And as I already said, the cause of the low plasma levels could not be established in any of the patients. Next. So then we found that in patients who have the low levels, what were the factors which could have been associated with the low levels? And in this study, we found the commonest factors on univariate analysis were the low body mass index, hypoalbuminemia, disease being bilateral, and presence of cavities. These were the 4 or 5 factors on univariate analysis. They were found to be associated with the levels. But when we did the multiple logistic regression analysis, none of them was found to be independently associated with low levels. But at least on univariate, we have these factors. And when we looked at the response to the treatment, similar factors were associated that which were leading to the poor response to the treatment. Now coming to the intervention, what we did. You see, initially when we started on these patients, the patients who were coming early, say within 4, 5, 6 months, and they were found that no, they are not responding. So we started doing the TDM and the levels were low. We just increased the dosages. We increased the dosages in a stepwise fashion, like INH from 300 to 450, rifampicin from 600 to 750. And then after 2 weeks, repeat the TDM. If the levels are still low, we'll go back to the next higher dosages like this. And we found these. So then we had a 2 group of patients. in one where patient had come to us early. Early, I mean, say within 5-6 months. So there, just by increasing the dosage of the drug was sufficient and patients responded. But then there was a group which is more common where the patient report to us, say at 9 months, 10 months, 12 months, or even 15 months, that they are getting this treatment, but they are not responding to the treatment. So here we found if we are already escalating the dose, that was not helping. So these patients did not improve when we just escalated the dose. So in these cases, we had to shift to the second line drugs, and we could retain one or two of the first line drugs, like INH high dose we can consider. But with rifampicin, the issue was that the rifampicin has interaction with the bedaquiline. So in case we shift the patient to second line drugs, and bedaquiline is an important drug in the second line, but the metabolism of bedaquiline is significantly affected by the rifampicin. So here we prefer to give bedaquiline rather than the rifampicin because these patients have taken rifampicin for almost 12 months or so. Now the second issue was that we did not have any institute in the country who were doing the TDM to the second line drugs. So we always had a fear in mind that once we switch to the second line drugs, whether they are being absorbed or not, how are we sure that they will be absorbed? Because first line drugs are not being absorbed, so we thought even second line drugs may also not be absorbed, which was logical. And we had no way to know whether they are being absorbed or not. So what we were forced to do was we were in the second line drugs, we were trying to give them as much injections, as many injection drugs as possible. Like we have injectables available for levofloxacin, moxifloxacin. Linezolid is available in injection form in the country. Then this thing, Oxy, then linezolid, then amikacin was available with us. And in very, very few, maybe 2 or 3 patients, we had to resort to Venom also, where we found that the patient had taken these drugs or was not tolerating. Otherwise, majority of the time by giving 3 or 4 injectable drugs and 2 or 3 oral drugs, and we found very good response. We found very good response to these second line drugs in these patients. Now, fortunately, in our institute, for last few months, we have the TDM available for second line drugs also. So what we are doing now is that we switch to the second line drugs, maybe along with one injection like amikacin, and then after 2 weeks of treatment at the same time of the day, then again we withdraw the blood and we subject them to the TDM. And we are finding that after escalating the dose once or twice, we find the levels of the drugs are within the normal range, and we also find that the patients are improving. And let me also share, you see, many times we do not get a sample second time to do the TDM. And this is not only in our country. When I reviewed the literature outside India also, even in countries like Canada, US, they also report that the second time TDM is not available because of some logistic reasons. So this is the field reality which we face. But the bottom line is now we do not have to resort to the injectable second line drugs so often because we have the TDM for the second line drugs available with us. So here we give the oral second line drugs with at the most amikacin, and if we find that the drugs are not being absorbed despite the escalation of the doing the TDMs, then we have to shift to the injectable agents in these cases. And like in this case, we all can see a significant response was seen by shifting to the second line drugs within 3, 4, 5 months. And I discussed with Dr. Sural, he has a vast experience in treating TB of his spine. He said even he was not expecting such a good response, which came. So that you see, they say nothing succeeds like success. Jo jita ho Singandar. So that means in case you shift to the second line drugs and patients are responding, we must keep this possibility open for these cases. How it works, why they are sensitive, they are not working, I do not have a clear answer to this. That they were sensitive, but blood levels were low. And now after the patients have taken for the longer duration, the first line they were not working. And we have to switch to the second line drugs and it worked. Really, the pathogenesis of this, I think as of today, is not clear. And very few studies, if you see globally, where they have studied the low levels, then the intervention, and then the outcome. Usually, most of the studies are talking about the low levels only. But the intervention and then followed by the outcome is there in very, very few studies. So I think this area is still evolving. We need to learn more. Right? In our institute, we have a small experience of these 8, 9, 10 years only. I think we need to do more. And now, fortunately, because we have the TDM for second line drugs, I think the things will change. We will be wiser by using these. So that's where we are. But we must think of this entity and act also accordingly. So that is my take on such cases and this case also. Thank you.
Thank you,
So
Dr.
there's one question in the chat box, like when do we decide in case of spinal TB, like we are discussing spinal TB. So in spinal TB, what will be the time when we can call as treatment failure on the first line drugs? The right time to send TDM samples in case of spinal TB.
So Dr. Sural is there, the right person to answer this question. Dr. Sural, please.
Yes, thank you. Very important and interesting question. The answer is very difficult. So, as I said, from whatever studies we've done, the most important is the clinical response rather than going on to a MRI or other investigations upfront. So, in the clinical response, what we generally check is number one, clinically, the fever. Is it usually by 2 to 3 months, fever subsides, and then the weight gain, loss of appetite improves. Sometimes loss of appetite may not improve because of the anti-tubercular drugs per se. And then we look at the clinical signs. For if there is a sinus, is it healing or not? If it's persistently discharging, tenderness usually comes down. Tenderness may persist even in a healed tuberculosis because in spinal tuberculosis, healing may occur by a bony healing or a fibrous healing. If it's a bony healing, what happens is that if the intervertebral disc has sort of migrated, prolapsed into the body because of the loading and the osteopenia, then the bone to bone vertebral body and end plates are coming in contact and a bony healing takes place. Then pain also disappears and tenderness also disappears. But some of them heal by fibrous healing. So in those cases, pain may persist and tenderness may persist. So pain per se is not a very good clinical criteria. So among the signs, the discharge, and if there are any cold abscesses, are the cold abscesses worsening or a new cold abscess occurring? So these are clinical signs of failure. Whenever we get, of course, we always try as per the uh, National Tuberculosis Elimination Program that upfront on the first time the patient presents, we make all attempts to take out the sample if possible. Right. So a lot of times you may have cold abscess, which is accessible and possible. You take out the sample and so that you know right in the beginning it's MDR or not. But sometimes when the abscess is pre-vertebral, like in this case, there was an abscess in the cervical spine, which was pre-vertebral and also behind the body going onto the dura. Now you cannot access that without a surgery, right? So if there is no indication of surgery, then we see the clinical response. So from my experience, if by 6 months, there is no clinical response, if there is clinical deterioration before 6 months, definitely we need to take out sample and subject it to the test for resistance. But now with this today's eye opener, also do the TDM. But if after 6 months the sample was not accessible and there is no healing, we should not just sit back and continue to give ATT for 12 months, 18 months, 24 months. We need to take out the pus from somewhere and subject it for the resistance. And of course, now this TDM. Does that answer the question? That clinical response is the most important. And apart from clinical response, I also would mention we also follow up the ESR, but not ESR may be elevated. So that's another, uh, uh, because I was listening to some of the neurosurgeons who continue to give, and on national platform they were speaking that they continue to give 18 to 24 months of antitubercular therapy based that the ESR is raised. So now ESR in a patient with spinal tuberculosis who may be having a neurological deficit and on a indwelling catheter, the ESR is bound to be raised, right, of recurrent urinary tract infection or for other reasons. If the ESR is raised only independently without other clinical signs, that should not be the parameter, right? So I think clinical along with ESR and weight. So the response means weight gain, healing of the abscesses. The another thing is, suppose a patient comes whose surgery has been done, and after surgery there's a wound dehiscence. So according to our experts, they consider it as a resistant cases. Now, but I will share with you an interesting case whom I had operated, and after surgery, anterolateral decompression for a paraplegia in the spine, a patient developed a derangement of the liver function test. So the treatment regime was changed. And after a few months, patient came with the dehiscence of the wound. So I thought definitely this is resistance. But we continue to check the for resistance, the CBNAT and the liquid culture. It showed no resistance, and we continued to give the drugs, same drugs, and it healed eventually. So tuberculosis is a very difficult disease. I can tell you from my experience. No two patients are same, and but today's eye opener that therapeutic drug monitoring definitely is a new arena. We should look for it, and I think we should do more research on this, and we should look into this.
Thank you, Dr. Suran, so much. And let me tell you, when we hear the word CBNAT from surgeons, sometimes they are not even aware what is the full form of CBNAT. But the way you are using this term, because you are into it and you are subjecting the patients to all these genotypic and phenotypic tests, so thank you for that. And
So
Dr.
just on the lighter side, when I did the first thesis on CBNAT, so that was in 2006. So that thesis got the gold medal at MAMC because nobody knew what is CBNAT.
So that's a good one. Dr. Srinath from NIRT Chennai, director, the new director who joined there, is sitting here, and I take this opportunity to thank him and his institute. We are having this TDM facilities in our institute only for less than 2 years. We have Dr. Devika who took this challenge, and not only the first line, and she is going for second line also, and we must thank her for this facility. The reason being, earlier, because nobody else in the country was doing it reliably. And NIRT Chennai was the only institute which I could rely upon, because this was a major therapeutic decisions for our patients, and we were having referrals. Still, we have the referral from all over the country in these cases. So we used to admit them, the patients who are from outside Delhi, and within Delhi, just admit for a few hours. And then, as I explained, we do this procedure, and finally we have 1 ml of the blood being sent to Chennai, and in a cold chain. So that used to be such a big stress on us that our target was by Wednesday we must do it, because if we do it on Thursday and doesn't reach there by Saturday, the sample will be spoiled, because it will not last more than 48 hours in the cold chain that we were doing. And also looking for some good careers services was another challenge. And in Chennai, very often they have floods and these things in rainy season. So 2-3 times it happened like that the sample was sent, sample reached there. The person called us that the sample has reached, but he says, I can't go there. It's so much of rain is there. It's all flooding, so I cannot. And in the bargain, we lost the sample. And patient had come from Nagpur to us, and she was admitted here for about 7 days for this. So we felt so bad about this, but we had no solution to all this thing. And NIRT Chennai was cooperating fully with us. One day I remember the sample reached late there on Saturday. Then the in charge there, he sent somebody, they got the lab open, they took the sample and put them in the cold storage so that it could be done. So this NIRT Chennai has been helping us a lot, and thank you, Dr. Srinath, for that, and I hope we'll keep on working together. And now we have our own facility, and so even others can also use this facility in selected cases that we can do the TDM for their cases. Thank you.
Dr. Srinath, sir, do you want to say something?
No. I'm just recently joined, so I'm also hearing about all the facilities that are available at NIRT, and definitely whenever anybody requires this facility at our institute, we'll be happy to help whatever is possible from our end. So thank you, ma'am. Thank you.
Yeah. Thank you so much, Dr. Srinath. Dr. Rajiv Tandon has been trying to ask some questions for a long time. Dr. Rajiv?
Thank you, ma'am. Ma'am, I have my initial question addressed to Dr. Praveen, if he is available there.
Yes, sir.
So, Dr. Praveen, I would like to know whether the patient was prescribed anti-tubercular drug from the private sector to begin with, or was given the DOTS treatment?
From the DOTS, sir.
So that
registered under NTP, sir.
Okay, then that brings my second question to the organizer, especially Dr. Singla, that whenever there is an issue of detecting low TDM, then the quality assurance of the FDC supplied comes into question. So that would have been my question, not related to this particular case, whether or not that batch of was subjected to post-marketing bioavailability assurance or not. Not exactly addressed to you, it is to the organizers of this CM. Because in FDCs, there is always an issue of getting low bioavailability of rifampicin and Isonex.
Yes, thank you, Dr. Tandon, for raising this issue. For those who are not aware about this, what Dr. Tandon is emphasizing is that whenever we try to make FDC, that is fixed dose combination, especially for INH and rifampicin, and not do it the correct way, then there are chances that the blood levels achieved by using this combination because will not be adequate as it is mentioned there because this combining the two affects each other. And if you remember in our country for years we were giving the drugs separately, not FDCs, because the reason was we are not very sure whether if we make the FDCs and then ensure the bioavailability of the drugs, it was a challenge. And then the government took this challenge and we switched over to the FDCs. Initially, we were having the WHO certified criteria for having the bioequivalence being studied, but that comes to be very, very expensive. So then the government switched over to our own the methods for this. But let me tell you, they have a very strict protocol for checking the bioavailability. So they randomly they check the samples from all parts of the country, and then only they say that yes, this FDC is acceptable. So they follow the protocol that in randomly in this group of batches which come out from the factories, they check it. So by and large, we believe that whatever drugs are available as FTC in our country, they are of good quality and they have the bioequivalence studies done. So that part, at least I am quite confident that we are doing.
Dr. Singh, my concern is that this scenario is one of the post-marketing scenario where that particular batch should have been subjected to the quality assurance test.
Yeah. So what is the question?
No, this is not a question. This is only my comment that this particular scenario where such a clinical event happened, then that particular batch of drugs should have been tested.
Okay, got your point. Got your point.
Thank you. Thank you.
Thank you.
There's one more question in the chat box is like, can should be seen in the continuation phase and the patient initially responded and then one can see that in the continuation phase patient is deteriorating.
Okay.
So could it be malabsorption or could it be the selective?
Yes. You see, when the question is patient, we are in the intensive phase, patient is responding, and then after some time you find that patient is deteriorating again. So in these cases, rather than focusing on the malabsorption, you see the commonest reason is we call it fall and rise. When we start the treatment, patient has drug-sensitive bacteria as well as drug-resistant bacteria. As we give good drugs, the drug-sensitive bacteria are being killed, but the drug-resistant bacteria are slowly growing. So at the end, say at the end of 2-3 months, most of the sensitive bacteria have been killed by the good drugs to which they are sensitive. And then now this is the time that 3rd month onward, the drug-resistant bacteria, they start multiplying. So at 4th month, 5th month, again we reach a stage where patient has majority of the bacteria, drug-resistant bacteria, is smear positive again, culture positive again, and then they go towards the failure. So in such cases where initial response is there and then followed by the recurrence of symptoms again or deterioration again, we should think of fall and rise phenomena and must obtain sample to look for any drug sensitivity among them. This is a common phenomenon which has been described in the books also, and we see it also.
There's one more question. You mentioned in your PPT there's that hypoalbuminemia and low BMI, a poor nutrition status of the patient could be one of the reasons for the malabsorption in these patients. So how to tackle with these issues?
Okay, again, very, very important thing. First of all, let me tell you, in diabetics, they have found there could be gastropathy, that their absorption is poor. Similarly, in HIV patients, it has been well documented, especially studies from the Jewish Medical Center. Pinocchio is the person who has done maximum studies in maybe around 1.5 decade back. And he has demonstrated that among HIV, the absorption of rifampicin is significantly low, and so much so, he said, he has published that when the CD4 count is less than 50, in some of the patients, the absorption could be to the tune of zero. They found that rifampicin levels were not there at all. So similarly, in malnourished patients, we may hypothesize that it could be because of some gastropathies that people are absorbing poorly. And unfortunately, in our country, almost I think 50-60%, maybe more, are malnourished. And we are also finding that lower the BMI, more the chances of non-response to treatment. So this is a factor that the malnutrition among TB, and it is also associated with the mortality also. So we have to take care of this. So whenever we start the patient on treatment, simultaneously we have to treat the malnutrition part also by giving a balanced diet to the patient. And now our Honorable Prime Minister has several schemes, Niksha Poshan Yojana, Niksha Mitra, etc., where we are supporting this patient by a good amount of diet. That is equally important. Thank you.
Are there any other questions?
There's one more question. Can low TDM lead to emergence of TB bacilli in the patient in long run? You already covered it, but
no, you see, we don't know. Ideally speaking, yes. Ideally speaking, if there are low levels and patient is continuing on the low levels, we believe that patient should have developed drug resistance. But what we are seeing, it is not happening. Indeed, you see, these are the cases where repeatedly they are found to be sensitive, but when we investigated, found the levels to be. So theoretically speaking, yes, they should have had the more chances of developing drug resistance. But maybe, when we are giving the drugs together, this was sort of important thing to learn from for us also. You see, the laboratory as for 1% proportion method, laboratory will declare as resistance when more than 1% of the bacteria in the given population is resistant. Now it could be 1%, could be 10%, could be 40%, could be 70%. We don't differentiate. So 1% proportion method, which is commonly used method in the lab, report says drug resistance. We believe that all the bacteria are drug resistant, but it is not so. So in these cases, I feel that in case you keep on continuing the low level of dosage, then you need bacteria who were say less in number earlier. Now more and more percentage of bacteria will develop resistance, and we'll have a report from the lab that now they are resistant. So that could happen in such cases. But the field reality is, as of today, in these cases, even after 12 months, 15 months of the so-called low dosages, they are not showing the resistance. And that's how we go for the TDM, and then we treat such cases accordingly.
Thank you. So there's one more question, though we are dealing with the spinal TB, but this is a question related to patients who are suffering from IBS, inflammatory bowel syndrome. Do we need to increase the doses of the first line injection?
Which syndrome?
The inflammatory bowel.
IBS, yeah, inflammatory confusion, inflammatory syndrome. No, you see, it's a special in this syndrome. Once you level it, first you have to be sure whether especially it happens in HIV with TB. It also happens in
IBS.
That is irritable bowel syndrome. IBS is irritable bowel syndrome. So what is the question in these cases?
Do we need to increase the doses?
I don't think so. Irritable bowel does not mean poor absorption. The etiology of irritable bowel is different than a poor absorption. So in these cases, to the best of my knowledge, there is not much role of giving the higher dosage or doing the TD.
Dr. Rahul has been raising his hand. Dr. Rahul?
Yes, thank you, ma'am. Actually, that question related to hypoalbuminemia and low BMI was fine. We have a treatment protocol officiated by the Principal Secretary of our state, which was laid down by a group of experts in the state. And we have 13 criteria of high-risk TB patients. And among those, there are first one is low BMI and low weight. So in order to address that, we are segregating those patients and following them with a set of blood investigations. So, sir, do you suggest that we need to add this test for serum albumin and if at all it comes down as hypoalbuminemia case, what additional thing we can intervene for all those patients so that we get a quick response, at least in terms of weight gain or a clinical response in terms of radiologically improvement or like their symptoms get improvised.
Thank you, Dr. Rahul. You see, I think as you are doing in your state, you have identified the factors, and at national level they call it differentiated TB care, wherein they try to find out the factors which are associated with poor response to treatment, or they're even associated with the deaths. The new document for the differentiated TB care is under process and soon will be released. And among them, as you correctly said, the low BMI is the one of the most important factors which are associated with poor response to treatment and leading even to the deaths. So by and large, you see, looking at specifically at hypoalbuminemia, yes, it is okay, it can be done, but overall, if you find the BMI is low, we can believe that they have low level of albumin in the blood. So their nutrition supplementation is the intervention which I think your state is doing. Specifically for low albumin levels, I think like high protein diet, which is a part of the nutrition supplementation, that should take care of. I hope it is. Is it okay for you? Whatever I have replied.
Yes. Yes. Thank you, sir. And I would also like to share with you the treatment protocol that we've made. And sir, like I'll personally share it with you so that you can provide the inputs, which is very important for us. So we can revise that as well.
Which state you belong to? Gujarat.
Sir, Gujarat.
Okay. Thank you.
Thank you, sir.
Dr. Singla, you said that, adding parental drugs helps. But there's one question that if we are not able to do TDM, should we directly put the patient on parental drugs?
No, definitely not. You see, first of all, you have to have a hypothesis in mind that my patient is not responding. Reasons ABC. Whether the drug levels are low, the quality of the drug is low, the regime is not correct, compliance is there or not. And then to say that the patient is not responding because of the low levels, it can be known only by doing the TDM. So once you do TDM, you demonstrate low level. Then first choice is the oral drugs, increase the dosages. But as per our own experience, if they are coming to you very late, like 9 months and 12 months of ATD has been taken in the low dosage, there what we observed was that augmenting the dosages, people were not responding. We had to switch over to the second line drugs. Now, as I already said, if you switch to second line drugs, two options, either all oral second line drugs or injections wherever the injections are available. Because at that time, we did not have the facility of doing TDM to the second line drugs. We had to resort to the injectable drugs. And let me tell you, we have had very good response. We have cases, if you want, we can share with you all, where we switched to the second line drugs, injectable form, and they responded. But now, as in this case, you see, other than Imicacine, all were oral drugs, and you see the response. Even orthopedic surgeon is saying that he has not seen such a good response, and he has a vast experience with all. So that means even oral second line drugs will be effective, provided we will feel comfortable only when we demonstrate the TDM that the levels are getting normal, because we've already lost 12 to 15 months of treatment by the time they come to us. So the now first choice should be the oral, with supplementation of 1 or 2 injectables. Do the TDM. In case we find the levels are being achieved, oral drugs should suffice. Thank you.
Are there any questions?
Madam.
Yes, sir.
Dr. Surat, you have a vast experience. Can you tell this case, particularly will you follow for that is clinically, radiologically, and bacteriologically? We are discussing regarding clinically how will you monitor or follow. How will you monitor or follow radiologically this case particularly?
Yes, thank you, sir, for the question. So if you see serially, the MRI, which was repeated before the starting the new regime, the abscess was there, right? So now, first is the clinical response as far as the active disease and its healing is concerned. The second is because of that abscess, what is happening, and the abscess is right on the cord there at the level of T7, T6, T7, T1, C6, C7, T1. So we always check for the any neurological deficit, any paraplegia, in this case, quadriparesis, quadriplegia. So that is our first concern in such cases, because there may be early signs of myelopathy, which, because in tuberculosis, another very usual neurological deficit is not a sudden deficit. It happens with the cord getting compressed from the front, because the abscess is behind the body, and the anterior, the ventral, the corticospinal tracts, they start getting compressed. So then there are very subtle signs of spasticity, which the patient may not realize, but patient may have a awkward gait, and some spasticity can have, like while walking, footwear is coming out, and then slowly the motor deficit worsens, and then he starts walking with the support, then he starts becoming bedridden. So when we examine, we find that the planters will be upgoing, and the upper limb, the Hoffman sign, would be positive. So we look for neurological deficit, and the bladder and bowel usually comes later. So in tuberculosis, the progression is slowly, and then when it becomes worse, then from the corticospinal tract, vestibulospinal tract gets compressed. So then it becomes a paraplegia, uh, more I mean there is a more motor loss. Once there is a rubrospinal tract, which is, and the other tectospinal tracts, vestibulospinal tracts, they are compressed. Then what happens? There's a paraplegia and flexion. And like you're talking about the low nutrition because of malnutrition and all, hypoalbuminemia. So such patients land up with bed sores, with flexor spasms, and complete flaccid paraplegia. So they are very difficult to treat. So such patients, clinically, we need to see the response as well as monitor the neurology. And if there is a neurological worsening, then that is the point where we need to operate. We do a corpectomy, we remove that collapsed vertebral body, and do an anterior uh, fusion with a bone graft and a plate, and so that decompresses the pressure on the dura. So that is about the neurological part.
Thank you, sir. Dr. Sunil, I have a question. Most of you, if the patient reaches AIMS or LNJP or MAMC, maybe you are able to take all these steps. What is the take-home message for the DTOs who are on the ground level examining the patient every day? So what is it that they should keep in mind, and what are the alarming factors which should, tell a DTO that this patient needs to go to a higher center now?
Yes, ma'am. Thank you. Very important question. So, because one is that you have diagnosed this as a spinal tuberculosis. Now, in the spinal tuberculosis, uh, if the patient is moving around, the moment he gets out of bed, there is a loading on the spine. Now, in tuberculosis, there is osteopenia of the vertebral bodies. With the loading of the spine, there's going to be a collapse of the body, and there's going to be kyphotic deformity, and the kyphotic deformity may worsen. And then, and along with that, of course, there will be the sequence of paraplegia I just enumerated. So that is why, if once you detect a patient with spinal tuberculosis, so I would advise the patient should be on bed rest. And if he's moving around, there should be some sort of a orthotic device for the cervical spine, a collar; for the thoracolumbar spine, what is known as traditionally the Taylor's brace, or the thoracolumbosacral orthosis. And the moving around and should be minimal, because during the intensive phase there is still osteopenia, and the drugs, from our experience, we have seen that takes 2 to 3 months for the response to take place. That is the critical time the patient is moving around, weight bearing, standing, walking. Then there's going to be kyphotic deformity, and that deformity cannot be reversed, right? And if it's a child, if it's a kyphotic deformity, and what happens is the posterior elements, because the classical spinal tuberculosis is, there's a paravertebral disease, like here in this case also, the posterior elements, that is spinous process and the lamina, is all normal. So if the anterior body is diseased and there's a kyphosis in a child, the posterior elements will continue to grow with age, and the kyphotic deformity will worsen. So in the peripheral hospitals or whoever is treating, I think we should ensure bed rest, orthotic devices, along with high protein diet and the anti-tubercular therapy. right? And if there is a worsening of any deformity or appearance of any neurological sign, patient needs to be referred. Ideally, I think whoever can be referred, if you're not able to take out a sample, that also in today's National Tuberculosis Elimination Program, we need to take out the sample right before starting the anti-tubercular therapy so that we can identify the resistant cases.
I think so. That's a very important information, because what happens is that in the field there is very less amount of awareness on this factor, and sometimes the patient is living on the second floor or the third floor, and he's being called regularly to dot center to take medicines and things like that. So the health worker doesn't even they don't try to find out what is the problem, why he's taking the medicine. Their mandate is to give the medicine, so the patient has to come to dot center, and they make it kind of compulsory for them to travel, climb stairs and everything. So I think that's a very important information.
Sir, there is one more question from you. We have discussed different scenarios of malabsorption, like BMI, low BMI, and hypertrophy. But in cases of HIV positive, we've seen that there is also absorption in HIV patients if the TDM shows low levels of the drug. So how to go about it? Should we wait for some time to respond to the treatment, or shall we switch to some second-line therapy or switch to injectables?
Yeah, I think logically speaking, in these now we have very good drugs for the HIV. We have first-line drugs, not responding second-line drugs. So rather than jumping to the after doing the TDM to these second-line drugs, I think we should try to treat HIV. And once the CD4 counts they improve, the viral counts they also come down. And if even after that it is persisting, that is the time we should intervene and think of the second-line drugs. Otherwise, it may be a little too early to shift to the second-line drugs in such cases. And I'm sure within 1 or 2 months, most of the HIV patients, if they are in the right hands, they will respond.
True. Thank you, sir.
Thank you, sir. So with this, we come to the end of the clinic. And just to summarize the case, today we have discussed a case from AIIMS Raipur, and Dr. Praveen Dubey had excellently presented the case. The whole team has prepared the case very nicely. Very clear-cut message that there's this patient with spinal tuberculosis. He was given first-line treatment for more than 7 to 8 months, and he was not responding to treatment. Following which they did a TDM, and they found that patient. Even before doing TDM, they did CBNAT, LPA, and liquid culture, and all of them came as MTB detected, but they were sensitive to all the drugs. So for this patient, when they did the TDM, they found that the level of drugs was low in the blood at 2 hours, at 4 hours, and at 6 hours. So they changed the regime, declared this patient as clinical failure, and they changed the patient to all oral longer regime and added injection amikacin along with that. As it can amikacin with that, and now patient is responding very well, and patient has there is good recovery radiologically also. So as Dr. Subal said, that we have to monitor this patient clinically. All the patients that we are treating extrapulmonary, monitor them clinically, radiologically, and bacteriologically, at least for 6 months. And if you feel that the patient is not responding and there is no obvious cause, like if their adherence to treatment is good and other factors are taken care of, we can think of doing the therapeutic drug monitoring and alter our treatment body. So thank you very much, Dr. Churul sir, for being there and guiding us. Teams from AIIMS Raipur, thank you very much. And we are joined by Dr. Ashok Bharadwaj sir, who is the chairperson of National Task Force, who joins us every month and is always taking a lot of interest in this clinic. So I would request, I would call him for his vote of thanks. Dr. Bharadwaj sir. Is he muted?
He's there. So mute him. He's muted. He is muted.
Sir, please unmute yourself.
He's traveling. I think sir is traveling. Sir, voice is breaking.
So still the voice is breaking.
So you're not audible. So yes, sir. Can you? I think you're unmuted now.
So now, am I audible now?
Yes, sir. You're audible.
So I must thank Dr. Ajay Behra and his team from AIMS Raipur for excellent presentation, interesting case. So the clear message was that by Dr. Rupak Singla and Sumit, if we are not able to have clinical response improvement, then we can shift to the longer regimen. And if the facility for TDM is not there, then we can shift to the injectable also. So here, I will like to request to NITRD Delhi, because we will not be able to provide this HPLC for all the colleges. I'm interested in medical colleges, but what we can request the Center TV division, who in turn can request the Secretary Department of Health, such that we have got multiple multidisciplinary research unit in each medical college in the country, and they have the provision to buy the equipments. So still till now this HPLC is not there in that list. If we can request the Secretary DHR, if they medical college, they are eager to purchase it. But if it is permitted by the DHR, then they will purchase it, and it will be very easy for TDM in the country, because I have seen for the last 6-7 cases clinic. So every time TDM is coming to the front. So may I request you to take up the case with Center TV division, and I will also take this with Center TV division with DDG madam, so that we can request the Department of Health Research for permitting medical colleges to purchase HPLC in the medical college. So thank you very much. Thank you, Dr. Sumit. It was nice seeing you after we met together with Dr. Bhanu Vasti. So thank you very much, madam. Thank you.
Thank you. Thank you, sir. So with this, we end our today's clinic. Thank you very much for joining us.
Thank you.
Thank you. Thank you, everyone.
Thank you, sir. Thank you so much.
Thank you, sir.